All right, hi everyone. Welcome to Behaviors and Behavioral Strategies with Children who have vision impairments. I'm going to start the slideshow from the beginning. All right, I am Tricia Weis. I am the Outreach Preschool Vision Consultant for the state of Wisconsin. And here's my email address and phone number if you need to ever get in touch with me. All right, so we're going to start with this picture right here. It's a little girl with her fingers in her ears, her eyes are shut tight, and her mouth is wide open. You can tell she's kind of screaming with her tongue back a little bit. An unwanted physical behavior can be described as an action performed by an individual because they're trying to tell you something that they verbally cannot. And even if they're verbal kids, many kids, when they're really stressed about something or that higher arousal level that we'll talk about later, sometimes they just can't come up with the words. And so then the behaviors come out. So can I have a volunteer, anyone that could guess at what this child is trying to communicate? Anybody?
It's much too loud.
Yes, that's a good one. And actually, with her eyes shut tight, she could be blocking out all sensory information, which I always call sensory overload. Every time I get kind of irritated with my kids just being crazy, I just kind of yell sensory overload, and they all know what that means because they get it themselves as well. So behaviors, it's a form of communication, but it's also a really good thing to check your own communication, asking what happened to you versus how are you. When you ask what happened to you, you kind of give them like an end to start the conversation or to be able to think about what's going on with them inside. Asking anything wrong versus what's wrong with you. Asking what's wrong with you is kind of more of that negative question of they feel like maybe they did something wrong instead of just anything wrong, which could mean a variety of everything. And also open up more of a communication and help with them to communicate with you because you are concerned about that. So we're going to start by kind of talking a little bit about what's going on in the brain. And Dr. Fidlin, I don't know if any of you have had the privilege of watching him last year when we hired him, or a few years ago when we hired him at the in-person conference. But one of my favorite things that I took away from his presentation is the focusing tracks that we have at the executive part of our brain, which is the frontal cortex, the front part of our brain. And most of us have between 3 to 5 focusing tracks. So there's one track, like right now, I have a focusing track that's talking to you about behaviors. And then I have these back tracks, okay? The back tracks, I don't get to determine what they are focused on. So the back tracks are maybe thinking about what to cook for dinner tonight. One of them's maybe monitoring my environment. Another one's thinking about what time my children might come home. And so if something happens and I'm focusing, talking to you, and all of a sudden my dogs start barking, for instance, it's going to stop me. It's called a focusing track switch. So my environment backtrack is going to come forward and it's going to monitor and find out if there's a problem. And then I find out, oh, it's okay. It's just a child walking in front of our house. And then it tracks back and then I go back to talking with you. That's called the focusing track switch, okay? Typical kids that have vision impairments have backtracks that a lot of times are auditorily focused. So basically they're hearing everything that we already tune out, the birds chirping or voices in a distance, a buzzing sound from a fan. They are unable to, a lot of times, really focus on things because their mind is constantly doing this track switch with every sound that they hear. They're the ones that they're sitting in the front of the class, but they could hear the kid tapping in the back of the class. They can hear whatever's happening outside, and they're unable to focus basically on the teacher. So what helps with that is a lot of times is that white noise. Placement help when they get into schools, but that white noise will block out all the other noises to help them focus. My daughter has huge auditorily focused backtracks in her mind, and she's one of those kids that has to put in earphones with a real light music to even do her homework. And she's very successful. She's in college, but her whole life, that's always how she's been. She cannot focus on getting her homework done unless she has her earphones or her earbuds in her ears. Some kids that have some of that low vision, a lot of times they're visually focused in their backtracks too. That's a little bit easier placement. Blockers that will black out, a lot of that visuals overload that's a lot of times in the classrooms, pulling them out in different rooms that aren't so chaotic for, assignments or tests. That helps them. But those are the kids that notice everything new, especially if, they have that really good part of their central vision left and more of their peripheral loss. That's where I see it most. But they'll ask about it. Oh, I see you got a new pen. I see you have a new picture over here on the wall. Oh, you got new books in the back. And they just can't focus because they keep noticing all the visuals that are changing, or the kids moving, or, twirling their hair beside them, anything that they could visually pick up on. Kids with ADHD can have up to 12 focusing tracks. And so what that means is not only do they have double the amount of focusing tracks, but they also have up to 4 focusing points at one time. And these are the kids, these are the people that we really need in this world. There are detectives, there are nurses, there are the people that we need in those jobs that need to have those multiple abilities to focus on multiple things at one time and notice things at one time. When they're growing up, it's a little bit harder for them because of so much of that focusing, that track switching going on. And so that's when, sometimes there's some kids that get on that medication, and what that medication does for ADHD or ADD even is it takes like a band, and it takes a band that kind of blocks out half of those focusing points. And so then they're only dealing with the typical points that us typical people without the ADHD or ADD have. So it helps them be able to focus. Kids that get on medication because of ADHD or ADD sometimes love it, sometimes do not like it. And if they don't like it, either it could be the wrong kind of medicine for them, but also when you're taking a band around half of those focusing tracks, it's also taking away half their personality, and they don't feel like themselves. So sometimes it works for people, sometimes it doesn't. And that's always, the conversation that you have with the doctor. Sometimes, like my stepson who had to take ADHD medicine, he liked it at critical points in his life. So he wanted to be on it when he was at the beginning of junior high, and then he wanted to be off. And then he wanted to be on that medicine again when more around that 10th, 11th grade, when big things were happening in high school and the testings, like all the big tests that were happening that were going to affect his ability to get into the college. So taking into consideration of what the kids are thinking too is also a big factor for that. And in this picture, we have a picture of the arrows going down, and the bigger arrows, the one arrow that you're focusing on right now. And then we have the backtracks. And if you can imagine these arrows going back and forth continuously, that kind of gives you an idea of what that's like in our brains. So another thing that's really important to happen in the brain is what's happening with the limbic system. So we're gonna take an example of a sound. A sound is heard, okay? And this is a real life experience I've experienced with one of the kiddos that I evaluated before. So what's happening when a sound is heard, a flapping sound is heard? The sound travels through the auditory pathway to the brain stem, decoding basic signals and location of sound. Okay, so that's the first thing that's happening. Next, the sound travels to the thalamus, the gateway that relays all sensory information except smell. So that's visual, that's touch, vestibular, all of that sensory information, except for smell. Smell only has one synapse path to the brain. But the thalamus is kind of like that gateway, and it's really connected with that limbic system, and I'll show you how. It's sent to the auditory. It should be sent to the auditory cortex for interpretation. Sorry, I can't speak. But the sound was taken as a threat and was hijacked. So when it's at the thalamus, that's when that information gets hijacked and sent to the amygdala for the emotional response. Okay, we all can imagine you're in a parking garage, and all of a sudden you hear a really strange sound. That information automatically for your own self is sent right away to the amygdala. Okay, and that's when all your hairs start happening in the back of your neck. Okay. The amygdala is overactive, and it takes it as a negative threat. So then what happens is it's sent to the hypothalamus for the fight or flight or freeze response. I don't have the freeze in there, it should be in there. The hypothalamus and the pituitary glands are buddies, and they're neurologically and chemically connected to maintain internal stability, okay? The pituitary gland controls the correct amount of cortisol hormone release for the situation. The hypothalamus sends the message to the body, and that's when you start, if you're in that dark parking lot, your heart starts beating faster, your muscles start getting tense. You may even kind of form a fist a little bit, just getting ready for that fight or flight response, or the fight if you're having the fist. The mind becomes overactive and starts thinking irrationally. That's when you start thinking, oh no, it's going to be somebody who's going to mug me, or even worse. And with kids that are hearing the sound, if they don't have on-body tactual hands-on experience with that sound, they don't even have the cerebral folders in their brain to actually come up with what it could actually be. So then the sound threat is stored in the amygdala for just the short-term memory as a negative emotion before it's sent to the hippocampus for memory conversion. They say that the kids with autism have a larger amygdala because of so much emotion is stored in that area before it's sent to the hippocampus. This is where you can kind of understand if you ever hear a sound, or if you even have a smell, if you have anything you see, it kind of reminds you of an old memory. And sometimes it's a good memory. It doesn't have to be a bad memory. I know the smell of that hot tar on a summer day always reminds me of playing outside when I was a little kid. The smell of coffee reminds me of my grandmother's house. The different colors will remind me of, my favorite outfit wearing as a little girl. So there's that emotion that's stored in the amygdala before it's sent to the hippocampus. That emotion also along with all the details of what's getting stored in the memory conversion area, that emotion is also sent with it. The amygdala is known to be overactive and larger in kids that have sensory defensive responses. Sorry about that. Jumped ahead of myself earlier. But when the threat is passed, the hypothalamus will start to regulate the body. Just kind of like your thermostat in your house. The heat comes on, and then it comes to that normal heat that you set it at 69 or 70, and then it stops and it starts to regulate your house. And this is what's happening in your body. Communicating, of course, with the pituitary gland to reduce the cortisol and regulate the body system. The muscles start relaxing, the heartbeat slows down a little bit. So one of the biggest things and one of the most popular diagnoses out there is the septo-optic nerve hypoplasia kids, or the kids with septo-optic nerve hypoplasia or dysplasia, which with this diagnosis, they're missing part or the whole pituitary gland. So children with this diagnosis usually have a lot of sensory processing issues or are sensory defensive. And it's pretty obvious if they have it. The pituitary gland is partially or fully not there and unable to work with the hypothalamus. So what happens is this will lead to out of control behaviors for a longer period because the gland isn't there to work with the hypothalamus and regulate the cortisol. So too much or too little is released, and the behaviors stay at a longer period of time because it takes a lot longer for their body to control itself. This will lead to behaviors in different and unfamiliar environments until they become comfortable and know what to expect. Basically concepts, as many concepts learned as possible, exposure, and routines are what eventually helps the behaviors for these kiddos. Also, that mindfulness training, how giving them tools and thoughts, providing them with things to think about to help calm themselves. Sometimes the ability to just remove themselves out of the situation. A lot of that gets put into the IEPs at school. Anything to help them settle themselves down. And this is any sensory information that's being sent to the body. I've seen a lot of it with touch, especially with these kiddos. Teachers will come and grab their hands, or another child will lightly touch up their arm and it wasn't expected because they can't see it or they didn't see it coming. In many people with the optic nerve hypoplasia or septo-optic dysplasia, the thick band of nerve fibers that connects the left and the right hemispheres of the brain, the corpus callosum, is underdeveloped or absent as well. And a lot of times this piece of information is missing. So there's an increased risk for cognitive or development delays as well with these kiddos. I don't know if you know what this part of that means, but this is the actual band of fibers that connects all information from the left side of the brain to the right and vice versa, from right to left. Many people with optic nerve hypoplasia may exhibit additional abnormalities too, delays in the skills that require the coordination of mental and muscular activity. Some affected children have normal intelligence and others have learning disabilities with intellectual disabilities. Autism is frequently diagnosed in children with optic nerve hypoplasia or septo-optic nerve hypoplasia, dysplasia. And here's a link that if you want to read more about that. Some kiddos, or there are some families that sign up for the signed up for the conference that have children with this diagnosis. So I made sure I covered that. It's also important for these kiddos to see the endocrinologist. It's a branch of medicine. Endocrinology is a branch of medicine that deals with the endocrine system, which controls the hormones in the body. Again, that's working with that pituitary gland. The physician who diagnoses and treats a wide range of conditions affecting the endocrine system. The endocrine system glands and organs release hormones that, like I told you before with the limbic system explanation, and a number of vital functions of our body. These glands include the hypothalamus, the pineal body, the pituitary gland, the thyroid, the parathyroids, adrenals, pancreas, testes, and ovaries. When a hormone reaches its target, it tells that part of your body that works what to do, when to do it, and for how long. So again, when they're in that flight or flight, right there, that's why it lasts so long with some of the behaviors that happens with these kiddos. Hormones are often referred to as messengers because they help different parts of the body communicate. They're involved in many different processes in the body, including blood sugar control, growth and development, the metabolism. It regulates your heartbeat and blood pressure, sexual development and function, reproduction, and mood, just to name a few. Oops, sorry about that. So now I want to talk about how kids with visual impairment learn and how you learn. So you learn from whole to part if you have full functioning vision. You walk into a room and you see a hole. You start seeing, where the windows are, or where the door is, and where the desks are located, where your favorite toy section is. No matter where you walk into, you're going to see the room as a whole, and then you're going to start picking out those pieces that make up that room. Kids with vision impairments, they learn totally opposite. They learn from part to whole. So they're going to walk into a room and they're going to find out from the door where the couch is and where the windows are, or where the desk is, or where their toys are. And that goes along with all concepts. And it doesn't matter if the child is totally blind or low vision. This is still the same. This is how they learn. They learn from part to whole versus how we learn from whole to part with full vision. And that's even with a toy. So a child with low vision or blindness, they're gonna look at all the little pieces that make that toy interesting, all the little parts or the textures or the temperatures and the colors, what things like move and what makes that toy. And then they're gonna put that whole toy concept into their brain after they see all the different parts. Does that make sense? I haven't seen any questions yet or heard any from Dave, so I'm hoping I'm not overloading anybody. I tend to do that sometimes. So using the senses. All kids are learning the world through multiple senses. This is how we all learn concepts, actually, through multiple senses. But so for instance, if there's something to hear, there's something to touch. If there's something to touch, there's something to see, something to taste. It always takes two senses to learn a concept. And I can explain this by helping you visualize maybe sitting on your couch. Okay, this is one of my favorite things to explain this area by. You could be sitting on the couch with your window behind you, and then you hear a truck coming, and you think it's the garbage truck because it's garbage day, and you it's the time when he comes every week, and you can hear that the truck sounds the same as it always has every other time. But a lot of times, and you'll find yourself doing this now because I've explained it this way, but a lot of times you will still turn to verify that it was still the garbage truck. You'll look out the window. This is using multiple senses. And your body automatically does that because if it was a dump truck, your brain wants to take in the new information that's made at the dump truck instead of the garbage truck. It's constantly, your mind is constantly wanting to learn. So your mind is constantly verifying information, and it's building up all those cerebral folders in your brain to put in new characteristics of this and that. And so you have multiple folders popping up for every situation. This is how we train ourselves knowing what we're hearing. This is how we train our brain to know what we're seeing, what we're touching, how we're moving. Kids with visual impairments and low vision, blindness, they need that extra time to build up those concepts, to get those multiple senses in, because most of us that have full vision, they automatically get that incidental learning. They get that automatic vision characteristics, and they just need that follow-up with a sound or a touch. And it takes more time when you don't have the vision. So let's talk a little bit more about behaviors. So, okay, a behavior's brewing. What do you do? Well, right off the bat, what you can do is switch the sensory activity. So for instance, and why we can do that and stop the behavior instantly is because all of our sensory areas in our brain are in different locations. So if somebody touched one of your very textually defensive kiddos, and you can start seeing in their body language or in their voice that a behavior is starting to brew. You can start singing or get them to move, have some smelling jars, anything to switch the focus, massage their shoulders, to get input into their bodies. That might prevent, and I'm not saying it happens all the time, it's not the perfect thing, but a lot of times that can prevent the behavior from getting huge. Because a lot of times, as we know, those tantrums, they can last some time. So you see a behavior happening. Another very, very important thing is because us adults, we take a lot of things for advantage because we are used to things. So we block a lot of sensory information out because we already know, we already have all those concepts in our body. We already know what it is, it sounds like. But if you see your child starting the agitation or even an interest, look around. What could it be that they're hearing or smelling? What could it be that their eyes are picking up, their vision? Or is something touching them that you don't know about? Even if you're outside, could it be a caterpillar on them? Anything that you can just kind of stop and take a look. Sometimes just the temperature. When you're walking around, there's a different temperature when you're walking next to a building versus an open field. And then explain to them, follow up with that hands-on hug the tree moment, or describing and giving them a second sensory experience so they can learn what that is that they're noticing. So the vestibular system is also something that's very huge and can prevent, if you know about it, can prevent some behaviors. So the vestibular system provides your brain with information about balance, motion, location of your head and the body in relation to where you are, your surroundings, your environment. And the vestibular system is in charge of not only that, but also anxiety, lower field tracking, balance, and depression, sadness. A lot of kids get huge anxieties, behaviors start from that. And a lot of times it's because their vestibular system isn't kick-started. Kids that don't have vision or have very low vision oftentimes don't play the same way that kids with vision play. They want to keep their head more upright and their ears pointed towards what they're listening to. They don't move their bodies all over the place, especially when they're a little bit older. And so they don't get that vestibular system kickstarted. Just like elderly people, because of our bodies and our joints and just our routines in life, don't often get our heads in different realms of space. And so you'll see a lot of elderly people, you have more aggressions or anxieties, or depressed faster. Doctors will give them ideas of getting their heads in different realms of space, just like embedding this in a child's routine to kickstart their vestibular system is also important. For instance, rolling a child on a ball back and forth 10 times and sideways 10 times, having them touch their toes, having them fall backwards on the bed. Any activity that can get their head in different realms of space, and 10 is a magic number for some reason, will start that vestibular system, and it's huge. Doctors will tell elderly people to do side dips in the chair 10 times on each side, or fall backwards on their bed or lean backwards 10 times getting up. If they have the muscular ability to do that with their stomachs. Anything touching their toes, to kickstart that vestibular system. It's huge. And a lot of teachers will actually put it in their routine that they roll them on one of those big exercise balls before they start their Braille lesson, or anything that requires a lot more attention. Talk to your occupational therapist about a sensory diet. They can give you all kinds of activities for visual therapy, for calming, colors, if they have some vision and ability to see colors. Auditory, they are experts at the smell, the oral, the tactile, the proprioception, input and pressure into the body, vestibular, bodies in different positions, and interception, the mindfulness. They are the experts that can come up with activities for you to do at home if there's behaviors happening at home. A lot of times you'll see kids that really need that proprioception, and you'll see behaviors happening because of it. You'll see them just drop every time they're on a harder ground, just to get that input into their hips. They're the ones that are just trying to push things off. And excuse me for a minute, I just got to take a drink. My throat's getting dry. And they'll also give you activities for calming, or for bringing them out of that low mode, that sleep mode, that lower arousal level. For instance, bringing a child that's kind of like dreary and spacey and not really alert, some crunchy snack to bring up their alertness and their arousal level. Swinging will be calming, that kind of thing. They'll help you out with any kind of activity or tools to put into the home to help out with those behaviors. So self-stimming is a behavior that you'll see a lot also with children that have visual impairments. And it's important that students who are blind get structured activities, lifting, pushing, and pulling heavy objects to get that needed input into their joints, muscles, and their connective tissues. This will help regulate the sensory processing and possibly keep them from self-stimming during activities that are academic and needing for more focus. And it's huge. A lot of people, what we do with vision is we help regulate our sensory processing visual. or just with small movements of tapping our leg or our knee. Now, boys, when they're just sitting and concentrating, most of the time they are moving some part of their body, and that's because male brains are developed where they need movement to learn. And so you don't want to have them stop what they are doing unless it's inappropriate, and then have them come up or help them come up with a different activity that's a little bit calmer and not so distractive. And occupational therapists can assist with these appropriate activities too. So you already heard me talk about arousal levels. Arousal levels, there's sleep, there's drowsy, there's quiet alert, there's active alert, fussy, and agitated. It's important to know what each of these arousal states look like for each of your kiddos. For instance, if you go back to agitated, I had a child that was one of my students, and she always looked like she was in active alert because she was laughing and she was very vocal. But we found out not too long after I started working with her that her laugh was actually her nervousness, and she was actually in an agitated state of mind. Learning only occurs in quiet alert and active alert states. The body will fluctuate between these two constantly during lessons or stimulating activities. New skills can be introduced at quiet alert or active alert states only. So if your child is not learning, check out the arousal level state that they're normally in. And learn how to bring them into that quiet and active alert level. Because if you're trying to, or your student, if you're trying to teach or work with your child of getting her to accomplish something, if she's at a higher arousal level or too low of an arousal level, it's going to be a waste of your time and her time, because learning is not. Hyperextended states are caused by overstimulation or understimulation. Know what it looks like. Provide pictures. Families often find it's very helpful if they find pictures of or little tiny video clips of what it looks like when their child is agitated or what it looks like when they're sleepy. Kids are often known to be at a quiet alert level, but it looks kind of like, but why it looks like they're sleeping is because their head sometimes are down and their ears are pointed towards what they're listening to. Often teachers will work on them to keep their head up and towards what they're listening to. But when they're little, they're usually pointing their ear. And there are things such as BrainWorks out there that will give you all kinds of ideas for those arousal levels too, and how to bring them up and them down. I heard a voice. Do we have any questions out there, Dave? Okay. So orientated reflex. Orienting reflex is when the brain is ready to take in that new information. That's at that quiet and active alert level. Active alert to the environment. And a lot of times you'll see the kids kind of move up and move forward. They're putting that weight right over their hips. And this is really important to know with those kids in the wheelchairs, because a lot of times they don't have the ability to kind of come up and forward a little bit, and they need, when it's time to learn, their chair to be upright. If it's one of my favorite examples is, imagine yourself driving and you're relaxed and you're kind of looking around and keeping track with the the drive and just enjoying and relaxing with the music on. But also, and if a snowstorm starts happening, what happens is the radio turns down and you move up and forward a little bit, and both arms or both hands back on the steering wheel, because you're ready to take on that new information and make sure that you're driving as safely as possible with the new conditions. So look at some more different eye conditions. So behaviors related to peripheral field loss. Peripheral fields, they're responsible for your side vision. That's the movement from your sides is what actually is making your eyes, if you would vision, move towards whatever it's noticing in that peripheral field. You're not seeing the detail, but you're seeing the movement. It's also in charge of your night vision. So if you know your child has deficits in the peripheral field or a vision impairment with an obvious field loss with the peripheral field, you want to really be mindful of what side you're coming up to them. If you're coming up to their side that's has the deficits, you want to give them a verbal warning to prevent alarm behavior. Change of lighting will cause huge differences. So if you're in a classroom that's nicely brighted and then they're walking out into the hallway, or you're walking from your nice brightly lit kitchen into the darkened family room at dusk, behaviors may occur, or they'll stop, they'll freeze. And if there's sounds heard, they could even go into that fight or flight response. Some kids, they just drop. It's kind of their way of freezing because they go from having some functional vision to a huge degree less of functional vision to use. Orientation and mobility specialists will work on, relying on textual guiding and until they understand their environment a little bit more. So to improve behaviors, help the child feel safe and secure by learning him or her to oncoming changes. And of course, like I just said, the orientation mobility teachers will teach them to textually see instead of visually see, to cope. And that's certainly something that families can also work on in the home. So that way all the lights don't have to be turned on before they move at ease in their own house. Behaviors related to central field loss. So behaviors can occur from people telling them to look at them when in fact they already are. This is actually called eccentrically viewing, which the vision staff all know about. A lot of times if they have a visual loss in their central vision or that little spot in the fovea, they have what they call the eccentric viewing, which is using the closest part of their retina and their peripheral area that's closest to their fovea, the macula, the central vision. That and a lot of times this is in different spots, mainly sometimes just in one eye. And so they could have a head tilt, they could have an eye turn, they could be looking down or looking up more drastically than just right in central. And sometimes it looks like they're purposely trying to avoid what is being directed at them or other people talking to them, when in fact they're actually looking right at them. Little kids will automatically come up with these behaviors, and a lot of times adults, because they want them to look at their faces when they're talking to them or look at the materials they want them to look at, and so they're actually refraining them from naturally automatically doing that by teaching them to look more in their blind field. Students will also have a lot of social problems. Friends at the distance, they may think they're snobbish because they don't see them waving across the room. students will not see the body language, which is huge. And vision staff with those social skill goals a lot of times will work on communicating with their friends about their ability to see. They can see them close up in some of their hand actions, but they may not see them across the room, or to let them know what they're thinking, because they aren't understanding that they're seeing an angry face, or whatever they're trying to communicate body language wise. So then there's the cortical vision impairment, behaviors related to the cortical vision impairment. Visual perception is the brain's way of understanding the eyes, what the eyes are seeing, which includes the color, size, shape, and direction of objects. A child with a cortical vision impairment will see and then they won't. So the visual perception is going to be there and then it's going to be gone. When you have a cortical vision impairment, your environment plays a factor, and the biggest factor of the ability to see. Also your body, if it's feeling okay, many things, but the environment is the biggest thing. And so kids that have a cortical vision impairment, they can do all this active learning and then get all this great intervention where they end up being able to use their central vision right away, and even have a 20/20 acuity. This is possible. This is actually something that happens continuously with our CVI kids, because their vision can continually develop depending on the severity of what happened in their brain that caused the vision impairment. But with the interventions that are out now, they're constantly enhancing more of their functional vision. But you can have this great automatic vision in environments at this higher level. But if you're walking down the street and you're using your cane, or you're still carrying your cane, because if something happens, like for instance, a guy I know was walks to work and will always carry a cane, because on his way to work, if there's an accident that happens, his vision will automatically shut down. And you don't know how long that happens for. So then you need to have that tactual understanding to get from point A to point B as safely as possible. So then you're relying on that tactual means. You're tactually seeing instead of visually seeing, until the environment plays a factor to help you be able to use your vision again. And that's the CVI and all of those areas. That's an entire different training that would take all weekend, basically. But very interesting stuff. Visual motor is the use of vision in hands to perform tasks. Examples of this are writing and drawing, tying shoes, putting on socks even, a lot of times. A child with a cortical vision impairment typically cannot perform visual motor tasks because that's one of the hardest things for them to do, is that eye-hand coordination. They normally look away and then reach. So they spot and then they look away and perform the motor. So to help you understand a little bit even more about visual perception, here's a picture here with some black and white blobs on it. So you can look at the picture, you can try to come up with all kinds of, maybe what this picture could look like. Is it fish in an ocean with rocks? Is it, some kind of a ice glacier? It could be anything. But if you see even a blurred image of what that actual picture is, and then you go back to the black and white blob picture, you'll automatically see what that picture was meant to be. So your mind can tell you instantly because you had the experience of looking even at the blurred picture of the dog, that black and white blur blob image is actually the dog. This is how your brain works. Isn't that interesting? It's good stuff. This is another really good thing too. This is a picture of eye movement and facial recognition from Yarbus in 1965, recorded what the eye movements are doing and how many times the eyes have to move to get all of the details of the picture of a face. So the first picture of the face, there's a lot more detail and shadowing and hair. In the second picture of the face, it's more of that black and white, not a whole lot of detail in the skin tone, a little bit darker of the eyes. And so your eyes are going back and forth a lot more. But as you can see below, look at how many movements your eyes have to make for your brain to gain all the concepts of the details of each of these pictures. Isn't that interesting? So then we're going to talk a little bit about the spatial temporal development. Mary Tellison presents a lot, actually nationally, on this, and she was my old partner. And so I really became very interested in learning all about this because it helps me in my job, especially when I was doing evaluations, to understand that development order of how we understand our body in space and in time. And the first area is your body space in the present. This means that the body and its boundaries are in that present moment. Interventions aim to help the child experience intimate space in the present time through exploration of touch and proprioceptive sensations. So this is, if you can imagine your baby, this is when you're playing with toys against their body. You're playing with, massaging their arms and their legs, or you're tickling them, or you're just playing with them and always touching them to play. That's that beginning stages of understanding, what toys are against your body, and who and the people. As soon as it's done, the time is done. Reach space and proximal time, mapping of proximal space, mapping of near range objects, and object-to-object relationship. This level includes distance at which a child can reach out to make contact with the world, and for what object permanence becomes key. Proximal time is the immediate past and immediate future. So this is that stage when kids understand that they're playing with an object, or they hear an object, they'll reach out for their favorite toy. It doesn't have to be a contact, because with objects, initially, we have to have that tactual understanding of an object before we can even see, before our brain can even learn that object. We have to have that sensory sensation tactually against our object first. But when the cerebral builds up those concepts of these objects that we've had in contact with our bodies, then they'll start reaching for those objects. Now, vision plays a big, huge factor in all of this. So this is when the toy drops, and they reach for the toy in that kind of like a circle around them. If you can imagine a big circle, arm's length around their body, this is their world. If it goes, those objects past that circle, then it's out of mind, and it's the immediate past. So it doesn't have to be against the body, but next to the body, basically. And then that next level is moving through proximal space and time, object to object, body to object, objects to body. This level organizes actions, plans to perform a task within the tactual, visual, and auditory space available through movement and locomotion. So this is when those kids are starting to cruise or crawling and getting from point A to point B across the room. They're seeing their favorite toy that mom took away earlier and put it away across the room, and they're wanting to get at it. This is another big area where that vision plays a piece in that development, because vision is the factor that gets you motivated to move across the room. It's out of that near space, of that arm's length space, and they want to move. They want to get to that, what they want, or their mom, or the sound, or the dog that's across the room, or the cat, anything that motivate them to move. And so when you're blind or visually impaired, this is where you start setting up motivations in little smaller increments to get them to move a little bit further and a little bit further and a little bit further. And the use of their favorite toys is always the biggest thing. Sounds, people, their favorite peoples. Siblings often play that game. The next one after this one I didn't put in, because that's more of that cognitive level where they understand their environment and they're mapping it in their head to get from point A to point B, and understanding that there's objects or there's snacks in the kitchen. And so they're planning on going to get that cookie that they can smell because mom just baked them, and how they're going to get from point A to point B to get that cookie. And that's usually around the corner or out of sight. But their mind and their cerebral is built up enough folders in there to start mapping that distance out. And that's another huge, this is just a touch of what this actually, the spatial temporal development means. This is another weekend, in service. So tactile before visual, on body before off body is one of the biggest things, even with kids that are older. If they don't have an understanding of the characteristics of something that, like a new object that you're bringing into the lesson, or a Christmas present even, they may be very defensive on grabbing it or touching it or using their vision to look at it, because they're not able to see what hasn't actually had experience with yet. Always play with the toys or objects on their body and under their hands first. And to know that their hands are their eyes. One of the biggest things that we stress in this field is never grab a child's hands to look. Hand under hand is what we stress and continually over and over and over and over again, because we can teach a child to actually be tactily defensive by grabbing their hands to have them look at something. So what this looks like with a hand under hand is you're holding the object, and then you're putting your hand that's holding the object underneath their hand. So if you can imagine maybe your child's hand or your student's hand riding the back of your hand. So their hand palm down is on top of your hand, the back of your hand. And then you're turning your wrist and you're offering them a chance to grab or touch the object or hold the object with you. This is an invitation to touch, basically. And if they move their hands back under their armpits or put their hands underneath their legs, they're saying no thank you. And this is a big, huge key, because if you respect that no thank you, I mean, you can always offer them to grab or touch that object later on. But if you respect that no thank you, they're going to trust you very quickly. If you don't respect that no thank you, and you don't give some time in between offering again, they may take a lot longer to trust you. And engaging with objects is how we learn. So a big, huge thing is respect and no thank you. And if you can imagine, it'd be like me taking a sighted person and forcing their head to turn left or turn to turn right to look at something. And even if you have low vision, your hands are tactually seeing as well at the same time as the functional vision is. So what is applied behavior analysis? This is always a big question as well. This is a therapy based on science of learning and behavior. It helps us understand how behaviors work, how behavior is affected by the environment, and how learning takes place. And this therapy applies to our understanding of how behavior works to real situations. The goal is to increase the behaviors that are helpful and decrease the behaviors that are harmful. And here's a link that helps describe the ABA a little bit further. The least restrictive environment. This is something under the ideal law. And this is one of my biggest passions. So I really wanted to add this in. IDEA is Individuals with Disabilities Education Act. And the least restrictive environment, the LRE, also seen abbreviations. We're really big with abbreviations in this field. Protect students for this, and I put a link so that way you can read more about it. But it states special classes, separate schooling, or other removal of children with disabilities from the regular education environment occurs only if nature or severity of the disability is such that education in regular classes with the use of supplementary aids and services cannot be achieved satisfactorily. So this is where most of the kids a lot of times will start out in the regular ed classroom to make sure that, you know, this is addressed, the least restrictive environment. But one of my biggest, this is my soapbox, is the placement sometimes in a regular classroom, and many times actually at different points of their life, kids cannot learn in. They are unable to learn in that sensory overload classroom environment. And a lot of times you'll see big behaviors come out of it because they're trying to communicate. They're not able to learn in there. They're in sensory overload for much of the time. And so this is where it's really important that if this is starting to occur with your kiddos, bring up that IEP and talk with the team about a different type of placement. Maybe, you know, maybe it's just being pulled out for certain parts of their learning, or it may be a different style of a classroom or a different classroom with a little bit less amount of kids. Sometimes it needs to be in even more of a restrictive environment that's created just for kids that have blind or visual impairments. But it's something people should definitely talk about. Yeah.
Trish, Melissa asks, do you have any suggestions about introducing her child to new animals? Their movement and so on sometimes makes him afraid.
Okay.
And I'm going to jump in quickly on this too, because I have a look for, and you're going to think this is strange, but look for a good taxidermist. And this is where, you know, these, you know, stuffed animals, you know, formerly living stuffed animals, you can get a chance to look at animals that you would not ordinarily get a chance to pet. It's hard to catch a bear to pet them.
You're absolutely right.
But find a good taxidermist and use them. As far as living animals, you know, it's more difficult. Dogs and cats, you know, you have to encourage the child to let the animal come to them,
yep,
rather than chasing it, because they do run away. I do like petting zoos.
Treat in hands will help that area.
Yeah. Petting zoos are always good. because those animals are used to being touched. But if you can, get your child to where he understands that the animal has some choices too, and the animal might not want to be touched. So if you're going to a farm, for example, it's probably easier to touch a cow than it is to catch a chicken to look at it.
Yeah, and the billy goats will be way more active.
Julie says that she started by fostering dogs and cats in their home to get the child used to that. And sometimes they're cuddly and sometimes they're not. But she says that helped.
Thank you, Dave. Thank you very much.
I'll mute myself again.
Well, I'm almost done here. I just wanted to put the DPI behavior support links. This is inclusive strategies to address behavioral needs for students with IEPs. So here's a couple of links that will address how to get more help if you have some behaviors that you're having a hard time addressing in the classroom or with the IEP team. This is where you can get some more help and support for them. And then think about this. We cannot force a child to learn, but we can create an environment with conditions that learning will most likely occur. Every child is going to be unique and different and the perfect them. And I have not met a child yet, and I've been in this field for many, many years, 22 years now, and every one of them has a beautiful soul, and they're just, every one of them are completely different and have a unique way of communicating. And so finding out and understanding how they're communicating and what they're communicating for us, even when they're verbally communicating, a lot of times they're also communicating through different behaviors or movements or other areas other than just the words, because they don't know how to explain what it is that they're thinking about or feeling.
And Trish, one thing you generally cover, and you haven't yet, is discussing how we as blind people learn. And it's very important to remember that most sighted children learn from general to specific.
Yeah, I covered that with the part to whole.
Okay, well, I must have fallen asleep, but
because you heard me speak so many times.
But we learn from specific to general, so that
Yes,
means
absolutely.
that we're not going to get. Well, for example, a tree is a round cylindrical thing that has a rough exterior, and we're going to have to get to look at a whole tree, to get the idea of how the limbs come out and how the leaves come out and all of that. Where a sighted child would look at that and say, this is an oak tree. That's good. Yep, the acorns come down from it and so on. So do the leaves in the fall. But what the blind child is going to get without some intervention is the fact that it's a round, rough, cylindrical object that drops things on you. So keep that in mind as you teach, because you guys are going to be the best teachers.
Yes, they're the first teachers too.